Good day to all. Start with our first topic with the competency number AN 44.4, Inguinal Canal. So let us travel in this abdominal ODC and find out and decode what is this inguinal canal is about, the boundaries of the inguinal canal, the contents of the inguinal canal, and how important it is clinically to understand what is an inguinal hernia. Right? So along with that, we will also see about the importance of Hasselbalch triangle and also the anatomical basis of inguinal hernia. Yes, so we will be talking through this subtopics that include extension of the canal, direction, formation of superficial and the deep inguinal rings, boundaries, and the content of the inguinal canal. Yes, what is the inguinal canal? It is a musculo-aponeurotic canal or a tunnel of approximately 4 cm. Okay, so it is a musculo-aponeurotic tunnel of approximately 4 cm extending from the deep inguinal ring to the superficial inguinal ring. So the canal is a 4 cm directed downwards, forwards and medially just above and parallel to medial half of the inguinal ligament. I believe you would have heard what is called an inguinal ligament. You would have seen inguinal ligament during dissection. So this inguinal canal is present just above and parallel to the medial half of the inguinal ligament, which means when I draw the inguinal ligament from the anterior superior iliac spine to the pubic tubercle, which is present here, the inguinal canal is present just above and parallel. This is a place where the inguinal canal is present. Okay, so it's a landmark. Okay, so the canal is directed downwards, forwards and medially just above and parallel to the medial half of the, so not the entirety of the inguinal ligament, but the medial half of the inguinal ligament. So this is a definition of the inguinal canal. Right, so you can look at the picture, you can see there are two extensions here. One extension here, this is the superficial inguinal ring, and you can see this is the another extension called the deep inguinal ring. So this is extension of the canal. So this is a musculo-aponeurotic canal. Okay, so this is a musculo-aponeurotic canal, which means this canal has got a muscular opening and also an aponeurotic opening. We will come to that in a bit. Okay, so the extension of the canal starts from the superficial inguinal ring and it goes to the deep inguinal ring. So let us discuss about what is the superficial inguinal ring and what is the deep inguinal ring for further understanding. Okay, so I told you it's a musculo-aponeurotic canal and this is also called house of Bassani. So look at the picture here. You can see the beautiful superficial inguinal ring present here. It is a triangular defect seen in the aponeurosis of this external oblique muscle. You can see this one here. This is the aponeurosis of, this is the external oblique aponeurosis. Okay, so it's a triangular defect formed by the external oblique aponeurosis during its attachment. Okay, and the extension goes deeper to the deep inguinal ring which is present here. Okay, so this deep inguinal ring is a defect found in the fascia transveralis. Okay, so let us discuss that deeper. First we will go into the superficial inguinal ring. So what is the superficial inguinal ring? Like I told you, it is a triangular gap in the aponeurosis of the external oblique muscle. You can all look at this picture here. You can see the defect there. It's a triangular defect present in the aponeurosis of the external oblique muscle. So it lies above and lateral to the pubic crest. Okay, so let me draw the pubis bone here. This is the pubic symphysis and let me draw the pubic bone here. Okay, so we can draw the two parts of the pubic bone here. We have the inguinal ligament which is coming and attaching to the pubic tubercle. So the projection is called the pubic tubercle. Okay, so we have the muscle called external oblique muscle. So this muscle directed downwards, forwards and medially, right? So when it inserts to the pubic tubercle in the form of an aponeurosis, okay, in the pubic tubercle, it creates a triangular deficit. Okay, it creates a triangular deficit. So, this triangular deficit is bounded base by the pubic tubercle, and we have the medial crura and the lateral crura. So, this defect is a superficial inguinal ring or the external inguinal ring. So, this defect is formed by the aponeurosis of external oblique muscle. So, you can look at the picture. The defect is triangular. It is formed by the aponeurosis of the external oblique muscle. You can see there, no? This is external oblique muscle, and this is the aponeurosis of the external oblique muscle. And you can see as it attaches to the pubic crest here, okay, it divides into a lateral crura and a medial crura. Okay, so this is the boundary of the superficial inguinal ring, which is bounded by the lateral crura and the medial crura of the aponeurosis of the external oblique muscle and based by the pubic crest. Okay, so this is the superficial inguinal ring formation, right? So the external oblique muscle, as it attaches to the pubic crest, so this word is important, as it attaches to the pubic crest, it splits into two crura, the medial crura and the lateral crura, thereby creating a triangular deficit called superficial inguinal ring or external inguinal ring. So this is how the superficial inguinal ring is formed. You can look at the picture once again. So this is a beautiful superficial inguinal ring. So this is the medial crura, I am highlighting here. This is the lateral crura, and this is the base will be formed by the pubic crest. Clear? So this is the superficial inguinal ring. So let us go into the deep inguinal ring, right? It is an oval shaped opening. I mean, the external ring is an triangular deficit. This is a oval shaped opening present 1.25 centimeter above the mid inguinal point. So let me draw the picture once again. I am going to draw the superficial inguinal ring here. Okay, so let me draw the canal. The canal, as you know, is downward, forwards and medially, and just above I will be drawing the inguinal ligament here. This is the inguinal ligament, okay, coming from the anterior superior iliac spine to the pubic tubercle here. Okay, so just above 1.25 centimeter above the mid inguinal point, we have a defect posteriorly in the fascia transveralis. So that defect is called the deep inguinal ring. So that's how the deep inguinal ring form. You can see the picture here. So this is a oval shaped defect formed in the fascia transveralis, okay, through which the content of the inguinal canal travels. Okay, so this is the extension of the inguinal canal. So when we talk about extension of the inguinal canal, it starts with the superficial inguinal ring to the deep inguinal ring. The superficial inguinal ring is a triangular deficit formed by aponeurosis of external oblique muscle. The deep inguinal ring is a oval deficit formed by the fascia transveralis. I hope I made myself clear. So now let us explore into the boundaries of the inguinal canal. Okay, so the boundaries of the inguinal canal comes into 6 ways: anterior wall, posterior wall, the roof and the floor, the inlet and the outlet. Okay, inlet and outlet you already studied. Okay, the inlet will be the deep inguinal ring, the outlet will be the superficial inguinal ring. Okay, so let us explore into the anterior, posterior wall, roof and the floor. The anterior wall, right? As you dissect, when you are dissecting the abdomen, you would have opened the skin, and as you open the skin, you would have come across the superficial fascia. And as you reflected the superficial fascia, the fatty layer, the membranous layer, you would have come across a muscle called external oblique muscle. Okay, so that forms the anterior wall of the inguinal canal. So this external oblique muscle, which extends downwards, forwards and medially, it travels downwards, forwards and medially, forms a beautiful anterior wall of the inguinal canal. Okay, so you can see this is the inguinal canal here, and you can see the external oblique muscle forms the anterior wall. So you can form the anterior wall of the inguinal canal. The posterior wall is formed by the fascia transveralis. Okay, the posterior wall is formed by fascia transveralis, but once again, you should all remember there, it is the posterior wall, since it is just covered only by fascia transveralis, it is strengthened by the conjoint tendon is formed by the internal oblique muscle and the transverse abdominis muscle. So the medial half of the posterior wall is strengthened by the fibers of the internal oblique and the transverse abdominis, together they form the conjoint tendon. Clear? And not only that, the posterior wall is further strengthened by reflected part of the inguinal ligament. Clear? So let us start. Once again, I take through to the anterior wall and the posterior wall. Anterior wall is formed by skin, superficial fascia, and external oblique muscle throughout. The aponeurosis of the external oblique muscle throughout. The posterior wall is formed by fascia transveralis, and the medial half of the posterior wall is formed by the conjoint tendon, which is nothing but the internal oblique muscle and the transverse abdominis muscle. So let us talk to the roof of the canal. The roof of the canal is formed by the arched fibers. You can see here the arched fibers of internal oblique and transverse abdominis muscle. I already told you these two muscles together forms the conjoint tendon, right? And the floor is formed by inguinal ligament, as you already know, and it is contributed by the lacunar ligament. It is nothing but the extension of the inguinal ligament. The inguinal ligament has got a multiple extension that include the reflected part, lacunar part, pectineal part, okay, and this lacunar part also contribute to the floor. Okay, so now when you look at the anterior wall, the posterior wall, the roof, and the floor, right? So the internal oblique muscle contribute to the anterior wall, posterior wall, and also to the roof. Clear? If you look at the description there, we can see the internal oblique muscle, okay, contribute here to the posterior wall. You can see through the conjoint tendon. Clear? It also contribute to the roof. So please remember that, because when we come to the mechanism of prevention of inguinal hernia, okay, we will talk about the action of this muscle. Clear? The inlet, as I told you, is formed by the deep inguinal ring. So it is formed by the oval deficit, okay, created by the fascia transveralis. It is situated 1.25 centimeter above the mid-inguinal point, okay, 1.1 above the mid-inguinal point, and the outlet, as I already told you, is a triangular gap formed in the aponeurosis of external oblique muscle, okay, it is situated above and lateral to pubic crest. So inguinal canal has got inlet and an outlet, anterior wall, posterior wall, roof, and a floor. Clear? So this is all about the boundaries. Once again, let me highlight through the boundaries. The anterior wall, skin, superficial fascia, external oblique muscle, and lateral 1/3 of internal oblique muscle. As I already told you, the internal oblique muscle contribute to anterior wall, roof, and the posterior wall. Okay, anterior wall, roof, and the posterior wall. Clear? The posterior wall is formed by fascia transveralis, and the medial 2/3 of the posterior wall is formed by the conjoint tendon, which is formed by internal oblique and transverse abdominis muscle. The roof is formed by the arched fibers of internal oblique and transverse abdominis, and the floor is formed by inguinal ligament and of course the lacunar ligament. So this is how you have to remember the boundaries of the inguinal canal. I hope I made this one clear. Now let us talk through the, once again look at this picture here. So this will further simplify. The anterior wall is formed by skin, superficial fascia, the external oblique muscle, and of course the medial half is also supported by internal oblique muscle. The posterior wall is formed by the fascia transveralis and the conjoint tendon. The roof is formed by internal oblique and the transverse abdominis muscle, and the floor is formed by the inguinal ligament. And you already know about the inlet and the outlet. Clear? So let us go through this picture here. This is once again we have put in a 6-sided cuboid shape. So this is anterior wall. So let's say this is a triangular deficit. Here it doesn't, the deficit doesn't look like that. It's a triangular deficit. Okay. We have the external ring here, the superficial inguinal ring present there, and you can see as you go deeper, okay, we get the deep inguinal ring. It's a oval deficit formed in the fascia transveralis. Clear? So this one forms a roof and this one forms a floor. Okay, the roof is formed by the internal oblique, arched fibers of the internal oblique muscle and the transverse abdominis muscle. The floor will be formed by the inguinal ligament. Okay, the floor will be formed by the inguinal ligament. I hope I made the boundaries of the inguinal canal clear to you. Okay, so let us now talk into the content of the inguinal canal. Right? So very important. Okay, not only in theory but also in practical. Okay, this one is very important. The content of the inguinal canal, spermatic cord in male. Okay, we have to differentiate here with from males and females. And the ilio-inguinal nerve is a common content. And for female, round ligament of uterus. Okay, for female, it is round ligament of uterus. So this is the content of the inguinal canal. For male, it is spermatic cord and ilio-inguinal nerve, and for female, it is round ligament of uterus and the ilio-inguinal nerve. Right? So now when you talk about the content here, okay, the spermatic cord here, we are talking about the spermatic cord and the round ligament of uterus forms the complete content. When I say the word complete content, okay, it extends from the deep inguinal ring, the superficial inguinal ring. Okay, so it travels here from there and goes up to the deep ring. So it forms a complete content. What I am talking about is the spermatic cord and the round ligament of uterus. But the ilio-inguinal nerve is a partial content. Okay, so it does not traverse from the deep inguinal ring to the superficial inguinal ring, but it pierces the internal oblique muscle and enters the canal halfway, okay, and reaches the superficial inguinal ring. Okay, so one of the recent question 2-3 years back, this question was asked, okay, regarding the ilio-inguinal nerve, and this question will be highlighted in my later session there. Okay, so ilio-inguinal nerve is a partial content, while the spermatic cord in males and the round ligament of uterus in female are the complete content. Okay, now let us dig into the content of the spermatic cord, and that include the ductus deferens or the vas deferens, 3 arteries, testicular artery, cremasteric artery, and artery to ductus deferens. We have a plexus of veins called pampaniform plexus of veins, lymph vessels, genital branch of genitofemoral nerve, and remains of process vaginalis. So we have to learn and by heart all the content present in the spermatic cord. Okay, so once again I repeat the content. You all see the first content, the chief content will be the vas deferens or the ductus deferens. 3 arteries, artery to testis, artery to cremaster muscle, and artery to vas deferens. So testicular artery, cremasteric artery, and the ductus deferens, artery to ductus deferens. And we have a plexus of veins coming out called the pampaniform plexus of veins. We have a plexus which forms from 16 to 8 to 4 to 2, and it becomes one vein. Clear? And then lymph vessels exit out, genital branch of genitofemoral nerve, and remains of process vaginalis. So these are the content of spermatic cord. Remember? So for males it is spermatic cord plus ilio-inguinal nerve. So that is why this is not being present here, because the spermatic cord, when you open the spermatic cord, when you open the layers of the spermatic cord, the external spermatic fascia, the cremasteric fascia, and the internal spermatic fascia, when you open up those layers, you will get these content present. You might have seen during the dissection at least an artery and sometimes a genital branch of genitofemoral nerve. These are the content you will see when you open up the spermatic cord. When you open up the layers of the spermatic cord, you will see this content. Okay. It is a very important thing. You have to remember and by heart all the content present in the spermatic cord. So once again, let me highlight what are the content. The chief content will be the ductus deferens or the vas deferens. Okay. And the next one will be the artery, the testicular artery, cremasteric artery, and artery to vas deferens. Artery to vas deferens. And the next important content, the nerve content, the genital branch of genitofemoral nerve. Genital branch of genitofemoral nerve. And we have the vein, the pampaniform plexus of veins, and the remains of process vaginalis. Okay. So these are the chief 5 content you have to remember when you talk about the spermatic cord. Clear? So main content will be the vas deferens, 3 arteries, 1 plexus of veins, 1 nerve, and process vaginalis. Okay. Along with that, please do not forget that. Okay. Ilio-inguinal nerve is a partial content of the spermatic cord. Right. So we have now traveled across the boundaries of the inguinal canal and the content of the inguinal canal. Now, we do have certain mechanism present in our body to protect, because the inguinal canal is an opening present from the abdominal cavity through the scrotum. Okay, so it is a site of a potential weakness. Okay, an anatomical deficit, a potential weakness. So herniation may happen through the rings. Okay, but there are some innate mechanism to protect the integrity of the canal. Okay, so let me go through some of the mechanisms, some of the important mechanisms which are present to protect from inguinal hernia. Number one, obliquity of the canal. Now, if you look at the canal, as I told you, the canal is directed downwards, forwards and medially, and it is from the posterior part of the layers, the fascia transveralis, and it travels through the anterior wall to the external oblique muscle. Okay, so it goes from superficial to deep. Okay, so whenever there is an increased intra-abdominal pressure, the anterior and the posterior wall get approximated. Okay, so the anterior wall which is present there and the posterior wall which is present there will be approximated so that it becomes one layer. So the rings will be closed. Okay, so the anterior wall and the posterior wall will be approximated in such a way that the superficial ring and the deep ring will be approximated and closed. So this mechanism is called flap valve mechanism. Okay, so you have to remember the flap valve mechanism, nothing but the anterior and the posterior wall gets approximated and closed in case of an increased abdominal pressure. The second, shutter mechanism. I stressed upon a muscle called internal oblique muscle when I talked about the boundaries. You remember? So this internal oblique muscle has got a triple relation with the inguinal canal. Okay, so this internal oblique muscle, okay, forms the roof, the anterior wall, and of course the posterior wall. Okay, so we have the roof, the anterior wall, and the posterior wall are covered by internal oblique. So when this muscle is pulled up during its contraction, the roof, anterior, and the posterior wall are pulled above in such a way that the canals are obliterated, okay, and approximated. Okay, so this shutter mechanism is beautifully done by the internal oblique muscle. Clear? So once again I repeat, the internal oblique muscle has got a triple relationship with the inguinal canal. It forms a roof in the form of arcuate fibers. It forms the anterior wall in the medial half, and it forms a posterior wall in the form of a conjoint tendon. Okay, so it forms a beautiful shutter mechanism during increased intra-abdominal pressure. Third one, ball valve mechanism. One of the protective reflex, considered to be a protective reflex. Okay, it is done by a muscle called cremasteric muscle. Okay, so every time when you stroke the medial aspect of your thigh, right, the cremaster muscle pulls up, okay, and closes the superficial inguinal ring present there. Okay, so we have the superficial ring present here. Okay, so we have the ring here. So every time when you stroke, or since it's a protective reflex, no, so what happens? The cremaster muscle pulls above and it closes the superficial inguinal ring. So in such a way that herniation do not take place. Clear? So the ball valve mechanism is done by the cremaster muscle. It is a protective reflex. Okay, so every time there is a danger, or when you stroke the medial aspect of the thigh, okay, the cremaster muscle is pulled above and it closes the superficial inguinal ring in such a way that the superficial inguinal ring is obliterated, so the herniation do not take place. And last, the slit valve mechanism is done by the external oblique muscle. When you look over the attachment of the external oblique muscle, as I told you, this external oblique muscle divides, as it reaches a pubic crust here, it divides into two crura present there. Clear? One is a lateral crura here and other one is a medial crura here. Right? So during contraction, we increase intra-abdominal pressure, and during contraction what happens? This crura, the medial and the lateral crura, will be approximated in such a way that the superficial inguinal ring will be closed. So this is called the slit valve mechanism done by the external oblique muscle. So each of the muscle contribute in preventing the inguinal hernia. Clear? So we have these 4 mechanisms present: flap valve mechanism, shutter mechanism, slit valve mechanism, and the ball valve mechanism. Okay, I hope I made myself clear with all these 4 important mechanisms. Okay,